some feedback, some comments. So with your discussions, you guys did a good job this week with the discussions and peer reviews and on the test overall. Good job with that. So just keep up the good work with the material. Last week we kind of learned about how the equipment worked, so how the fluoroscopy equipment worked. This week we're gonna kind of learn about like its functions. So the control panel, the areas that we're going to be in using fluoroscopy. So we're going to talk about how the machine is controlled by us, the technologists. All right. So first we're going to start off by our role when we are in a fixed and an RNF equipment room. So when we looked at these last week. So basically this room is a room that has fixed X-ray equipment, but it also has fluoroscopy. So you can do both in the room. So if you needed to do any chest X-rays or anything that can be done, you can do things on the table as well, but it doubles as a fluoroscopy room. So in this room, if we're doing fluoro, the radiologist is going to be your primary operator. They're going to control the tower, the table, and they will be taking the exposures. As technologists, what we are going to do and what we should be doing is, number one, preparing the contrast. So if there is any type of contrast that the patient needs to drink, get that together. Or if we are having to put contrast somewhere like in a BE or small bowel small bowel series, if they have to drink it, or if you're doing a BE, prepare that. Make sure we talk to the patient like we would if we were doing a regular X-ray. Get a little history on the patient. Make sure that they are prepped for the exam and make sure they understand what's going to happen. So explaining the exam to the patient. Then administering contrast. So we may be the ones when the radiologist, if we're doing modified barium swallows or barium swallows, when the radiologist needs to kind of view the contrast going down the patient's throat as they swallow, we would be the ones holding the cup with the straw to kind of direct the patient so they can do the swallowing. And then assisting the patient with positioning. So if the patient has to lay down on the table in any way or stand up, we kind of help guide the patient into the right position, depending on what the radiologist is needing. So our role in mobile fluoroscopy is going to be a little bit different because we are going to be the operator. No radiologist is going to be there unless you're working like in an interventional suite. But mainly we're going to be using our C-arm in the surgery setting or in the operating room. So if that's the case, then we're going to be the primary operator. And we're also going to be the eyes of the surgeon. So basically we use the C-arm, like I said, in surgery or operating room, and interventional special procedures. A lot of times interventional special procedures is going to be the same department. In the cath lab and endoscopy and to assist with cystographies. So one thing you guys need to kind of keep in mind is that you do have to have two different mobile C-arm procedures that you have to comp to be completed for your ARRT requirements. So you have to do a C-arm procedure, which requires you to do manipulation to obtain more than one projection, or like in a surgical C-arm procedure. So this requires manipulation around a sterile field. So you will have to have two different types of comps. So just keep that in mind. Reading through you all's discussion for last week, I noticed we have a few people that have been able to see fluoroscopy, use it, or just kind of observe, and that's good. But the majority of you guys have not had a chance to experience it. But I would say the biggest kind of thing with using a C-arm is basically just learning how to manipulate it. And of course, whenever you get into your clinical areas or your jobs, ultimately your jobs, you'll be trained by somebody who probably has been doing it for a long time. A lot of times places have dedicated surgery techs. So they'll have techs that's all they do all day is surgery. Some people actually like the surgical environment. It's fast paced. It can be a little hectic, but some people they thrive in that and they like it. So there is opportunity if you are really good with the C-arm or you really like surgery and being in that area. A lot of times that can be your main thing that you do. Sterile field, that's the term that if you took my patient care class, we talked about a sterile field in that class, maintaining a sterile field, how to set a sterile field up when we're in the surgery environment, making sure that we don't contaminate the surgical or the sterile field. So surgical radiography. So that's basically when we take the C-arm to surgery to use during a surgery procedure. What are the requirements? Number one, you got to have teamwork. There are a lot of moving parts in surgery. So we are a part of the team in that room to make sure that we're getting the imaging that the doctor needs to do what they need to do to complete that surgery. Sterile field, knowing where your sterile field is in proximity to your machine, and knowing where it is in proximity to where you are to make sure we don't do anything to contaminate the sterile field. Hospital surgery policies and procedures. So being familiar with those when it comes to being in the surgical environment. A lot of times, all we really need to know is like the proper equipment, and making sure the shielding is there. People have the proper shielding. So that's going to be our main roles when we go to surgery. Knowing how to operate the equipment and then being able to communicate. It, like I said, in surgery, it can get to be hectic a little sometimes. And everybody's wearing masks because you're in a surgical, sterile environment. So, learning to kind of read cues and listen, for the things that the surgeon wants, or either, you make friends with the circulating nurse or the nurse, and they can kind of help you out if you don't really hear what the doctor's saying. So, they're gonna perform a timeout. Usually we are in the room when they do the timeout because that means they're getting ready to start the procedure. So they want to identify their patient, make sure they're doing the right procedure, make sure they're at the right surgical site. And if there are any patient safety concerns, they talk about them before they start the procedure. So like I said, one role that we have in surgery is that making sure everybody is going to be protected. So as well as us being protected. So when we are in the surgical setting, of course, we're going to make sure we have our lead aprons. We're going to make sure that everybody that's in the surgery suite has lead aprons. They do this all the time. They're used to it. A lot of times, if you have like different reps that come in or different people that come in that are not necessarily there all the time, we have to direct them to get lead. But most time, people know what to do if they're going to be using fluoro in the case. So making sure we have our lead aprons and other personal protective devices, such as our thyroid shield. If you have lead lined glasses, using those, make sure that they're there and you have them on, everybody has them on. Verbalizing exposures. So normally the surgeon may shout out fluoro or shot or something like that. So that's kind of verbalizing into for everybody in the room to know that the fluoro is going to start. But for some reason, if you're in there and you're taking pictures, post pictures, you want to verbalize to anyone in the room before you pull the trigger. So they know that you're getting ready to make an x-ray. So they either need to step away from the tube, step out of the room, or either put some lead on. Making sure we are following our source to image distance, our SID, and our object to image distance. So making sure our C arm, we have the patient lined up within that C. Because if we kind of adjust that, it's gonna affect the patient's dose. So making sure we have the patient lined up in that C properly. Being mindful about magnification. So with magnification, does anybody remember when we use magnification, what happens? What three things increase when we use the mag mode or magnification? Okay, got a couple of answers. Okay, so three things, you guys are on the right track. Three things that are affected or increased when we use magnification is we increase the contrast, increase spatial resolution, but we also increase patient dose. So we have to be mindful of using the magnification mode on the fluoroscopy machine or the C-arm. And then collimation. Is there any collimation that we can do to kind of, help? Uh, a lot of times with C-arm, there's really not a lot of collimation that can be done. Usually you can kind of hone in on one area, so kind of zoom in, that's your mag mode. But really, we don't have a lot of collimation. You can sometimes in neuro cases, if you're working with the spine, we may be able to collimate it a little bit. But sometimes, depending on the case, you may not be able to manipulate the collimation. One thing to remember when using the C-arm or when using fluoroscopy is that your patient is going to be your greatest source of occupational dose due to scatter. So just keep that in mind. The patient is going to be the source when you're using fluoro. All right, so how do we reduce dose? So beam restriction. What is beam restriction, or what is considered beam restriction when it comes to using C-arm or fluoroscopy? Yes, beam restriction is gonna be the same thing as like collimation. We want to try to collimate as much as we can. Like I said, depending on the case that you have, you might not be able to. But a lot of times, like when we're doing barium swallows, or if you're doing something with the neck or the spine, you may be able to collimate in a little bit. So beam restriction, collimation, less tissue irradiated, it's gonna be less dose to the patient. So pulsed or intermittent fluoroscopy. So this is when the fluoroscopy automatically is turned on. So the radiation beam is turned on and off by the person operating the fluoro machine. And then they can really set the rate. So what it's like they hit the fluoro, it will go for like a couple seconds and then they can take their foot off of it. But in that time, it's either pulsed at 30, 15, or 7.5. Usually the radiologist will set that because that's a user preference, how they like their images to kind of be pulsed, or how long the pulsing takes place, versus continuous fluoro, where they have their foot on the fluoro for a continuous long period of time. You never That's not necessarily good. It may be needed for some cases, but it's not necessarily going to be the best thing to do. So like we said, there's 30, 15, or 7.5, and just an example. So 5 versus 15 pulse, there's 5 less exposure and 15 more exposures. So 5 pulse is going to be 5 less exposures. 15 pulse, you're going to have more exposures. So source to skin distance, SSD. Can anybody tell me what source to skin distance is? Do y'all remember what source to skin distance is? SSD, source to skin distance. So you guys are on the right track. So your SSD is the distance from the patient's skin to the fluoro tube. Not to be confused with SID, which is the distance between the X-ray tube and the image receptor. So source to skin distance SSD is the distance from the patient's skin to the tube. So with our fluoro equipment, and our fixed equipment, so the room that the fluoro machine in the room fixed is 15 inches. And with our mobile equipment is 12 inches or 30 centimeters. So limit magnification. We already talked about magnification. And then the 15% rule. Do y'all remember what the 15% rule is? Anybody remember what the 15% rule is? So basically what it is that if we increase our KVP by 2, then we should half our mass. Yeah, increase the KVP. So if we lower our KVP by 15%, we have to increase our mass. If we increase our KVP, we have to lower our mass. So that's basically what the 15% rule is. All right. So reducing occupational exposure. Of course, we know we wear our lead aprons, lead eyeglasses, lead gloves, because sometimes when you do small bowel series, the doctor may have a lead glove and kind of touch the patient's stomach to kind of separate out their intestines. They also have this little it's a paddle. They call it a paddle. And it has like a balloon in the middle. And sometimes what they will do is they'll kind of inflate that balloon, which it has the same little ball on the end as you would have if you're inflating a blood pressure cuff. It has that on the end, and it kind of works the same way. It has a little device on there that you can turn to keep the air in, and then you can turn it to let the air out. But they use the paddle sometimes. But using the paddle that keeps their hand out of the field, but sometimes they don't have a paddle, have to use the lead glove. So their hand is going to be directly in the imaging field. They will use the lead glove. And then our distance. So we know about distance, time, and shielding. Using the remote, because the remote allows us to stand back. Making sure we are 6 feet away. The inverse square law, and then using 90-degree angles. So one thing that the fixed fluoroscopy machine has is a protective lead curtain. And this is not necessarily the best picture of that, but it's in the very front. We usually keep this on because, like I said, the patient is going to be the source. That's going to be the source of scatter. So that lead curtain protects not only the person operating, but the person assisting as well. So X-ray tube location. So we know in our fixed fluoro room, we learned that the tube is at the bottom and the image intensifier is at the top. Same concept with the fluoro tube. Our tube is at the bottom, image intensifier is at the top. So it should mainly stay that way. We know we can manipulate the C and put it at a 90-degree angle. So that means turning that C all the way around and getting us a 90-degree angle. But the X-ray tube above the patient and the image intensifier below the patient is going to be the greatest occupational exposure. So this position right here where you have your X-ray tube above your patient, image intensifier below, there should never be an instance where you use this. And if somebody is doing this, they don't have experience using a C-arm, because you really don't have a reason to put your tube on top and your image intensifier at the bottom. It should always be your X-ray tube on the bottom, image intensifier on the top. Now, like I said, you will maybe have to manipulate the C. You may have to bring the intensifier over, or kind of bring it down some to depending on what's going on, if you need the angle. But you should never, never, never have the X-ray tube above the patient and the image intensifier below the patient. So surgical team, when we go to surgery, who all is there? Gonna have a couple people in the room with you. And like I said, we took the patient care class. We kind of went over this in patient care too, so it should kind of be a review. So you're gonna have the group that's sterile. So you'll have your surgeon or surgeons, your first or surgical assistant. So you may have a PA, a nurse practitioner, or RN that's kind of helping, and then a scrub tech. So those are going to be your people that are going to be sterile. Your non-sterile people are going to be your circulating nurse. They kind of circulate the room, make sure everything is going. If something is needed, they can kind of go get something. So they're kind of circulating the room, just making sure everything's going okay. Your nurse anesthetist or your anesthesiologist, they're gonna be in the sterile field, not in the sterile field, I'm sorry, because they're at the head of the patient, making sure the patient is sedated and that they don't wake up from the sedation, and also making sure that the doctor knows the timing of how long the patient has been sedated, because they have time limits. A perfusionist, a rad tech, which is and maybe a medical device rep. So you can kind of see you got your scrub nurse right here. Got another scrub nurse. You have an expert operator, which would be a surgeon. You may have a resident fellow, a new doctor, the assisting. You see your anesthesiologist and your circulating nurse right here. So when we go into surgery, what do we need to wear? Can't just walk in there just with regular clothes on if a surgical procedure is going on. So you always want to have scrubs on. That's what you probably have on when you go to work. Then your surgical gown. If you do put a surgical gown on, that means you're entering the surgical field, but most of the time the surgical gown is for the people that are going to be in the sterile field, a part of the sterile team. Masks, always going to wear a mask. Everybody in there is going to have a mask on. Surgical cap should be worn because you want to cover up your hair, and get all the hair out your face, and make sure that no hair gets out or in the room. Always gloves and shoe covers. I usually, especially with shoe covers, I always recommend that you use them. The people in the sterile field are gonna have them on, but we have like booties when we go in there. The people performing the surgery, they're probably gonna have the shoe covers or the covers that come all the way up, because if you're working with blood, bodily fluids, it can get on the floor. Gloves, they have special sterile gloves that they put on before the surgery, but we should have a pair of gloves, keep some gloves, just in case we have to touch something outside the sterile field that's maybe contaminated with blood or bodily fluids. And then a C-arm cover. So we are responsible for making sure the C-arm is draped in a sterile drape. The a sterile member will help us because it's going to be part of what's on that sterile tray, but it's our responsibility to make sure that it is used, because it's going to be required for the procedure. So this is pretty much what a sterile drape looks like. Usually what happens is the member of the sterile field will kind of help you get it on. Then they'll put these little rubber bands to kind of tie it in place. And if we have to do an adjustment from this side, what we normally do is we'll put our hands in the inside and kind of pull it, not touching the outside, because basically this is the part that's going to be going over the patient or in the sterile field. Sterile versus non-sterile field rules. So here are the rules if you're in the surgery environment. With the sterile team, there's front to front or back to back passing. So you should never pass in front of someone who's sterile. So just make sure you remember that. They're gonna be sterile from waist to shoulders, and then 2 inches above elbow. So usually when they go wash their hands, that's why you see they wash their hands. They're washing all the way up their arms to their elbows, because that's part of them being sterile, and that's considered sterile, 2 inches below the elbows, all the way down to the fingertips. Your table from waist up, that's gonna be considered sterile. From waist or table height, I'm sorry, table height up is sterile, table height down is non-sterile. Equipment, like I said, C-arm covers, which should be applied by us. Of course, it's gonna be sterile because it's going into the sterile field. So in addition to the C-arm, which has not only the C arm, but it will have a control panel. So sometimes they have a control panel on the actual C arm. Sometimes they have a kind of a separate tower with two monitors on it. Just depends on the manufacturer. There also are mini C arms. There are O arms, and then we can also use our mobile or portable machines in the OR as well. And if we do use the portable machine, the image receptor that we're going to use to take the image has to be sterile. So that has to be, if it's going in a sterile field, it has to be draped in a plastic sterile cover as well. So the person who's helping you with the drape will also help you to get to with that image receptor, putting it in the sterile plastic. So, to kind of just go over the C arm, like we said, you have your actual C arm. Your image intensifier is going to be above the patient X-ray tube. Below, they'll have monitors, which is going to be your workstation. Like I said, it will depend on the manufacturer. You may have a monitor on the actual C arm. You may have a separate tower. Then you have a couple controls. You have your foot pedals, which usually we call that dead man switch. You can give that to the person that's operating, and usually what happens is they'll kind of use the fluoroscopy as needed. And that needs to be covered. We usually cover that in some plastic, but it's not because it's sterile. Because remember, from table height down is non-sterile. So that foot pedal is going to be considered in a non-sterile area, but we usually cover it in plastic so no blood or bodily fluids gets on the dead man switch. You will some devices do have a remote. So if you need to make an exposure, you can stand away, but there is an exposure switch on the machine. It just depends. The ones that I've worked with, they have it's a remote, but it's tethered to the machine. So it's attached, but you can kind of, it has enough slack on it that you can get far enough away from the beam. So your monitors, you'll have two, maybe three. One is going to be active and working. So you can actually switch these to one that's active and the one that's kind of holding image. So if you ever use the last image hold, it may be on the right. This is the last image hold is what the surgeon is going to use to reference if they have to do any type of adjusting of hardware, needles, screws, and pins. But this is also going to depend how you're set up in the room. Don't want you guys to like freak out about this, because when you go into the surgery environment, more than likely you're going to be going with somebody who does this a lot and works with specific surgeons. So they'll know what that surgeon likes, or either the doctor will tell you when they get in there which side they want to look at, if they want to look at the left side versus the right side. And it also kind of depends on the orientation you are in the room. So our O arm kind of looks like a C arm, except you can see it does close all the way. O arm is normally used in like spinal procedures, orthopedic procedures, or sometime in trauma instances. It does provide multi-dimensional, like 3D images. As you can see, it kind of looks like a CT scanner once it gets closed up, but it doesn't stop where the C is on the C arm. It kind of will cover and close, so it's going to give you a little bit better, a little bit more detailed images. And then you have a mini C arm. So a mini C arm is just what the name says. It's a miniature version of the C arm. It functions the same way as the big C arm. Usually the surgeon operates it, but it's usually used for smaller type procedures like hands, fingers, maybe toes, stuff that you don't need a big coverage area for. They'll use a mini C-arm. All right, control panel. So this is how we make the magic happen on the fluoro machine. So, like we talked about earlier, you may have a remote. The remote allows you to make an exposure, but you do have a control panel where you can make some adjustments to your image. Usually, your these two green buttons allow you to kind of raise the C up or raise it down. And then this yellow button is going to be your exposure button. So you can either make the exposure here by touching or pressing this button or using the remote. Or this is what I refer to as the foot pedal or dead man switch. Usually this is going to be given to the person in charge of the surgery or the surgeon because they usually control this. Usually, sometimes with, and it just depends on cases, you'll have a higher dose when you use the foot pedal or you let the surgeon use the foot pedal. And within reason, because if they're doing a vascular case or if they're doing a neuro case, they may need to use that live picture a little bit longer than, if it was like an ortho case. So some common surgical procedures that we use the C-arm for can include cholangiogram or cholangiography, retrograde urography, orthopedic procedures. So if they have to do closed or open reductions, internal or external fixations, or intramedullary fixation. So if they have to place pins in 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 your hand, wrist, ankle, foot. Then if patient has a hip fracture or needs a hip replacement, laminectomy if they're doing any type of work on the spine, fusing the spine or something like that. Pacemaker insertion, usually that's done in the cath lab. Arthroplasty, lithotripsy, which is breaking up kidney stones, and then microdissectomy. So those are just some of the surgical procedures or common surgical procedures that we may use a C-arm for. Okay, so now we're gonna go over the different buttons on the control panel. You guys probably, there is a video that you were supposed to watch this week that's gonna kind of go over each one of these. You should be using a video to do your worksheet, but we're gonna review them really quickly. So you have a couple buttons. You have an expose button, you have an alarm reset button, which you see right here. It's clearly labeled alarm reset. So what that means is every fluoro machine has a 5-minute timer on it. So what that means is you can only do continuous fluoro for up to 5 minutes or a cumulative amount of fluoro for up to 5 minutes. Doesn't mean that you can't use more. It's just gonna make a noise, give you like an alarm to let you know, hey, you've reached the 5-minute mark. Usually what they like is to stay under the 5 minutes. But just in case, there is an alarm there just to remind you, hey, we're at that 5-minute mark. So that's going to be your alarm reset button right there. So the buttons right here, this is going to, these two buttons, image flip. So if we have everything set up on the screen, but it may be flipped. It helps us put it in anatomical position. Or if the doctor wants it flipped, we can flip it left to right. We can flip it top to bottom. Just depends on what the surgeon wants. And then also it allows us to kind of rotate the image in a circle. So we can kind of take the image and it'll kind of turn it in a circle. Different cases call for different things. You just need to know that those are the places that if you need to do that, those buttons kind of handle that. Next is magnification mode. So if you're normal, just normal how you're supposed to be, this green light be on. If you mag up once, it'll make this green light next to it come on, or mag up twice. So magnification is just us, kind of coning down, or doing a close spot film on the area. So next is going to be our collimation buttons. So our collimation buttons, like I said, allows us to kind of collimate in if we're working on usually it's gonna be spine work, that they use the collimation buttons on. Then you have your shutter buttons. So basically it's a way for you to kind of, not necessarily a side to side collimation, but kind of going down into like say you were doing L5S1, something, a surgery there. So if the doctor was wanting to really get in and get a good look at L5S1, you can kind of make it like a spot film, and kind of cone down to just have that circular view of that area. And then your other collimation basically lets you open it up top to bottom. Uh, if you need to collimate that way, and these buttons allow you to open it from side to side. All right. Next is our contrast brightness. So this is gonna control our contrast brightness. So you can manually adjust your contrast and brightness if you need to. So if the image looks kind of dark, you can lighten it up a little bit, or you can hit auto and the machine it'll try to work for you and correct it itself. Next we have our KVP, our mask buttons. Yes, like ABC. Oh no, so the contrast is not ABC. Your ABC buttons are gonna be your KV and mask buttons. Those are gonna be your your ABC buttons. So you can, if you need to adjust the KVP or the mask, um, you have the availability to do that, or you hit that auto button and it will automatically give you a dose. Um, we already talked about the alarm reset button. You have a pulse button right there that allows you to kind of set what we were talking about, pulse imaging. Um, and then this film button, um, that allows you to just take a spot film. Your low dose button will basically, it'll drop your mask or your MA. So if you're doing a specific type of procedure, and great detail and contrast resolution isn't that pertinent, you can hit low dose and it'll kind of adjust your technique to give it a lower dose, but the picture quality might not be as good. Then you have your image save button. So if you need to save an image, you can hit that button. You have your workstation. This is where you can change, either put the image on one side, on the left monitor or the right monitor, or vice versa. And then you have your mode button. Um, that's going to basically let you use subtraction mode. So sometimes, or most of the times, they use subtraction mode in vascular cases. So if they are letting contrast run through the veins or arteries and they're kind of looking at that, they'll use subtraction mode for those images. So along with those operational buttons, there are different ways to kind of manipulate the actual machine. So you can steer it. It does have brakes. You can do what's called transverse. Move the seat, actually move it in and out. You can move it vertical. Like I told you, these two buttons on the top handle that. So you can move the seat up and then you can move it down. Head to toe, so north to south. So you can basically say you have the tube centered at L5S1 going in just like this, going in straight. But the doctor says, hey, can you come up? I want to take a look at L1, 2, 3, and 4. So it allows you to move the entire machine up to L1. So he can get a possible picture. So, and then it allows you to move all the way back down to L5S1. Wig wag, I like it says wig wag, swing head to feet. It's more like a sweeping motion, so you can use it to kind of sweep from head to feet. Then a tilt or angle or oblique, and then an oblique or lateral. We're gonna show you which things operate that. So this right here is gonna operate your north to south. So if you need to go north to south, this button right here is gonna operate it. So usually here's your brake right here. So usually you gotta take it off brake. And what this does is you see how these are turned to the side. Normally they would be turned facing forward because if you're driving it forward. But what this lever allows you to do is turn those wheels sideways so it can go head to toe. Then if we're gonna move in and out, this button will do that. So if you notice behind the control panel, if you're standing behind here, um, there's a button right above that tube. It locks and then it unlocks. So this will allow you to move the actual seat arm, like move it in or move it out. So talked about this. This is the up and down buttons right here. So it actually allows you to move the entire C arm up or move it down. We talked about north south. This button right here, that's gonna be your wig wag or your swivel or your sweep. So it allows you to kind of move. The machine stays like stationary, but it allows you to kind of swivel the C. And then lastly, you have this button right here, which allows you to manipulate the C. So the actual C. So take it from like a C, you can angle it forward, you can angle it to the side, you can do a cranial caudal angle, you can do a cranial angle. So this button is the button that allows you to do that. Then this button right here that's closer to the C, um, it allows you to go to a lateral position. So if you are doing spine work and you do an AP, they've just placed some pins or some screws and they're needing a lateral. You use that button, release it, and it allows you to kind of turn the machine to be at like a 90-degree angle. So like it has right here, so you can take a lateral picture. So just a couple more demonstrations of that button, how you can kind of angle it this way, a certain amount of degrees. And if you need to go a little bit steeper, you can do that as well. So that's what that button allows you to do. All right. That's all I got for you tonight. Do y'all have any questions for me? Going once, going twice. Let's see. Will these buttons be different on the image intensifier machine versus a flat panel machine? So these buttons are going to be more for image intensifier machine. You'll have variations for them on flat panel machines, and then you'll have variations of them on your fixed fluoroscopy machines. But some of the buttons are kind of universal, some of the function are kind of universal. It just differs from manufacturer to manufacturer. So everything that's on your test, we cover in the slides and in the lecture. So you should be good to go. And another reason I really didn't do a study guide this week is because we really don't have a chapter that's referenced in the book. Like last week, we had like a chapter, but the book really doesn't kind of hone in on the equipment. So the PowerPoint slides are gonna be your best study guide this week for your test. And I pretty much went over majority of what's gonna be on the test in tonight's lecture. All right. If y'all don't have any other questions, you can type your name in the chat box for outgoing attendance, and y'all have a good rest of your night. Will this specific PowerPoint be available? So the PowerPoint that's in the that's loaded in there, that it's basically the same PowerPoint. Same exact, it's um just a different design on the slides. So it's the same PowerPoint, same information.